Hi, good morning. Welcome to classroom. Very happy to see you all after a period of 2 weeks. And looking forward a great discussion today on a very common topic, traumatic brain injury patient coming for decompressive craniectomy. It's a very common scenario, and here we are having our experts to tell us how do we manage this scenario. Hoping for a great interactive discussion. Today, I'm very glad to invite our faculty, Dr. Sudhir from Bangalore. Hi, Dr. Sudhir, how are you?
Good morning. I'm fine. Thank you very much for inviting.
Yeah. Thanks for coming. Thanks for making your time to attend this classroom.
Yeah.
Along with us, we have Dr. Saurabh. Hi, Saurabh. Good morning from Delhi.
Good morning.
Manish is there. Hi, Manish. Prasanna, today at home, relaxing. Thank you. Thanks all for coming. Hi, Dr. Rahul. He's there.
Good morning.
Some literature search and review.
Yeah.
So I'm presenting Dr. Anil. He is my resident, and he'll be presenting the case scenario. Straight away, we'll go to the case scenario, and then we'll discuss on how to proceed with that.
Sure.
Let me share my screen.
Good morning, all of you, sir. I'm Dr. Anil.
Yeah, just a second.
So,
okay, so this is a case scenario. Go ahead, Anil.
yes,
present the case.
22-year male college student fall from footboard of a moving bus.
So the mode of injury was the college student was pushed away from a moving bus, and it was a moving bus, so it's a high velocity injury, right? Next.
So loss of consciousness was there on the scene, and patient had bleeding nose and bleeding per mouth, and seizure was there at the scene for a shorter duration, and the patient was brought by ambulance and shifted to the hospital. On the way, patient had vomited twice, and he was not responding to the commands. Patient was taken by the ambulance 108
to the hospital. On the way, patient
hospitals.
Yeah.
Okay.
So on ER arrival, patient was having compromised airway and noisy breathing. Saturation was maintaining 100% with oxygen supplement. Patient was not tachypneic. On auscultation, bilateral air entry equal, and pulse rate was 108 per minute, BP 160 by 100, and pupils were pupils were right 2 mm reacting to light and left side 6 mm not reacting to light. And temperature was 35 degrees centigrade, and GCS was E2V2 M3.
Okay.
So we have done rapid sequence intubation, and we have secured the airway with ET tube size number 8. And we have done, before that, we have done the manual inline stabilization, and we have applied the cervical collar. Without applying cricoid pressure, we have no cricoid pressure was applied. And then we have intubated the patient.
Okay, just a second, Anil.
Yes.
I'll just share the case scenario to them because the slide was not seen.
Okay, sir.
So it was a 22-year-old male college student who was pushed from a moving bus. It was a high velocity injury, and there was a loss of consciousness on scene. He was unresponsive, bleeding profusely through the nose and mouth. There was a seizure witnessed at scene. It aborted itself. He was brought by the ambulance by scoop and shift, and he vomited twice on the way to the hospital. On arrival, he was not responding to commands. Compromised airway with a lot of secretions, noisy breathing, a lot of bleeding through the mouth and nose. However, he was maintaining good saturation with oxygen supplement, and there was no tachypnea. Bilateral air entry clinically was equal, and he was hemodynamically stable with a heart rate of 108 and BP of 160 by 100. However, his GCS was low. It was E2, V2, and M3. It is less than 8. And significantly, he has anisocoria. Left side pupil was greater than the right side. And his temperature was about 35 degrees Celsius. So in the ER, the interventions include a rapid sequence induction, but without a cricoid pressure. A direct laryngoscopy was used with manual inline stabilization to stabilize the cervical spine. And he was intubated, a C-collar was applied. He was ventilated. Hyperventilation was initiated at this point of time. A 500 ml of normal saline was given. Boluses were used to maintain a mean arterial pressure more than 90 millimeters of mercury. Propofol infusion was started, mannitol given, and after mannitol also the pupils were unequal, so 3% in a 300 ml bolus was given en route to the CT scan. And the fosfenetine 1000 milligram was started in the drip as a loading dose. Now I'll stop the presentation and I'll go to our panelist and I'll ask them what they will do in this scenario. So first I'll go to Dr. Sudhir. Dr. Sudhir.
Yes, sir.
Do you believe that these interventions which were done were appropriate, or you think that something else could have been done, or you would have done something different?
More or less, what has been done is reasonably acceptable. Initially, GCS was less than 8. That's a straightaway ATLS indication that airway has to be accessed at the earliest.
Okay.
And manual inline stabilization, they've gone with the ATLS protocol. And manual inline stabilization, yeah, cricoid pressure is a controversy, yes or no. Yes. I would prefer not giving any cricoid pressure if the airway is reasonably all right. So it's not very difficult. So airway access, maintenance of oxygenation and circulation is utmost importance at the initial level of management. So before the patient comes to the theater. So any blood pressure less than 90 and any SaO2 less than 90 should be treated and optimized before anything else. Yes, cervical stabilization with collar, preferably a collar with posterior support and which can anterior airway can be removed is ideal in case we need to access the airway in an emergent fashion. And the only thing is query is here in the management whether mannitol was ideal in that particular situation without a CT scan. So that is one thing. I would prefer as soon as the airway and patient is reasonably stable. So here airway has been accessed. The earlier we do a CT scan, so we can the further management can be planned properly.
Okay, no doubt denying that early CT scan is must in this patient, but clinically, if you see the patient has got a low GCS and one side pupil is dilated, so unless otherwise proven, it's herniation.
Yeah, unless otherwise proven, it's a severe raise in ICP and herniation. Yes, mannitol, yes, has a choice. But in this patient, if possible, immediate CT scan and then take a call with that. Mannitol, so yes, of course.
What is the reason for that? Why do you want to avoid mannitol in this scenario?
One thing is we don't know what is happening, whether there is a isolated injury or there are multiple injuries. Normally, these kind of acceleration, deceleration injuries will have coup and contra coup injuries. There might be a small EDH somewhere. The moment you give mannitol, there is decrease in pressure. The EDH might, someone will see that in our scenario. So, if the patient is stable, of course, if the ICP is raised too much and patient is unstable, the mannitol definitely will help with stabilization. Mannitol, yes, you can give it. There is no harm, but the earlier the CT scan is always the better in this kind of case where everything is stable.
Okay, all right. I'll just go to Saurabh then. Saurabh, how would your management be? Do you agree with Dr. Sudhir? Or?
Yeah, I agree. The one thing is that the use of propofol in emergency situation has been rampant. And in general, in my emergency, I have told people not to use propofol as an induction agent in a head injury patient because there's a fall of blood pressure, tremendous, which is, I think, associated with a poor outcome in initial few hours. So I have told them to go with fentanyl midazolam or a thiopentone straight away, whichever way they are comfortable with. But I have restricted the use of propofol in emergency as an induction agent, because there is a sharp fall in pressure and most of the time emergency people are not aware of it. They take time, they are still using NIBP for 15 minutes, 30 minutes, and that's sometimes maybe a problem at that moment of time. Rest everything is fine. I agree.
You mean to say you should not use propofol, or you have to improve your standards of a ER to make
see it's both ways. So
blood pressure.
See, most of the time you have to follow a protocol because you have no control over the ER department. The patients generally have been received by ER and then then they are shifted to a neurocritical care unit. But if in the initial 1 hour or 2 hours, which the patient is
So
with,
how about etomidate or ketamine in this scenario?
yeah, etomidate can be used. Not sure of ketamine.
Not sure of Dr. Manish. You will be having some idea about ketamine in this scenario because Dr. Saurabh is very much worried about propofol being used in ER, that the ER may not handle the hypotension properly, that are deleterious consequences. But having said that, if you give midazolam only without anything, you can also have unnecessarily increase the intracranial pressure in this
Yeah, I
patient.
thought fentanyl, midazolam, and a relaxant. I have not talked about only midazolam.
Yeah, that's what midazolam and relaxant, which is a very weak anesthetic agent. Yeah. Yes, Dr. Manish.
Fortunately, our ER is probably better and more responsive because I have sensitized them to monitor blood pressure more frequently. Most of the times they put arterial line also and do IBP monitoring. So
So
for
do you
induction,
want to place arterial line in the ER and waste time before doing a CT? Because
no,
Dr. Sudhir
no,
said we have to shift to the CT scan as
no,
early as possible.
I'm talking about monitoring of blood pressure. Not immediately they put arterial line, but after some time, yes, they put. The point is that using propofol is not bad until unless you take care of arterial pressure.
All right.
I mean blood
So
pressure.
what is your comment on ketamine? Because nowadays a lot of articles are coming that it is a myth that we should not use ketamine in neurological.
I would like more literature to come, but in this case, their blood pressure was already on higher side, so that I will not use ketamine. I would use propofol. May not be 2 milligram per kilo.
So if the blood pressure is low, would you use ketamine?
I do not use ketamine even when the blood pressure is low. There are two problems associated with ketamine. One, we do not know its effect on traumatic brain injury very correctly. The other is availability, because now ketamine is registered under opioids and there are some problems regarding procurement of ketamine also.
All right. And Dr. Prasanna, your comments, please, in the initial management of trauma.
Regarding this intubation, I feel you use whatever you are comfortable. Avoid hypotension, use whichever agent. You have etomidate, you use.
So that's a very good point, that you have to use a agent which you are familiar with and you are comfortable with.
Yeah, and avoid hypotension, and meantime do a resuscitation. If you see in this patient particularly, the saturation is okay.
Correct.
So you have sometimes stabilize the BP, give some fluids, and then you can go for intubation. Because here main point is of protecting the airway than improving the oxygenation. So that's okay, fine.
So
you can use whatever.
Yes, Dr. Prasanna nailed it. It is the maintaining the hemodynamics, which is the key, which is common to all speakers, all the faculty who are told the agent you use depend upon your familiarity and your setup. How do you use that? Right. Very good take home message. Okay. Having said that, what about mannitol? When you see a patient in a core brain situation, even before CT, it is recommended to start reducing the ICP. So do you use mannitol? Because Dr. Sudhir wants to wait till the CT and then he would decide on mannitol. So what do you say?
Yeah.
Is there any harm in using it, or you go for 3% saline? Because I know that you more often favor 3% saline over mannitol. So what is your protocol? What do you suggest?
So if your CT is very nearby, like maybe in a 10 meters or so, where our emergency department is available, rather I would do a CT early, then go for a mannitol. See, because some isolated EDH is there, which is likely to point. It may happen that the size of EDH may increase when you give mannitol, at least theoretically. So better I would go for a CT early and then give back the mannitol. If it is nearby, I'll get a CT done.
So after induction, this patient had a hypertension. It was managed with fluids and phenylephrine infusion. So what is your fluid of choice? What was your fluid? What is your fluid now? And what will be your fluid in these patients for resuscitation?
So as far as the resuscitation is concerned, any crystallite. When the BP is low, I will go for any crystallite. Okay.
Okay.
So it may be RL, it may be NS, or it may be plasmalite, whatever is available. So I would, in a head injury, I would go initially for INS. For
So you don't have a preferred fluid in this scenario.
no, not if I am going for too much of fluids, particularly like a 3 liter, 4 liter, then I would start thinking what is going to be the fluid of choice.
Do you still practice that fluid resuscitation of 3 liters, 4 liters before blood transfusion?
Now, how do you give blood? Because you don't have a proof that blood loss is there.
Okay.
There is a hypotension. Crystalloids is the treatment of choice, right?
Okay.
So if a systemic injury I am suspecting, along with that, I would search for that and start the blood. Nowadays, you can do a bedside hemoglobin. If it is less, then you can start blood. Otherwise, it's the fluid always is the treatment of choice.
Now, forget about even bedside hemoglobin. If patient is a transient responder or a non-responder, you will resort to an early hemostatic blood transfusion strategy, or you go with fluids.
Yeah, this that is what. If it is isolated head injury, you will not do a hemostatic.
You will not know. You will never know that it is an isolated head injury unless you do a CT scan.
That is true. No, but if there is any other associated conditions are there, for example, a fracture femur, okay, or a then you have to rule out the intra-abdominal this like a fast scan or ultrasound, something only. How do you start a blood unless you have an indication that there is a blood loss?
All right. So you had a valid point that unless there is a bleeding somewhere in the thorax, abdomen, or femur, you will not start blood transfusion. But I'll quickly go to Dr. Manish. Dr. Manish, even though it is not described very clearly in the books, at times even skull-based fractures, oropharyngeal bleeding, and nasal bleeding can be torrential. It can cause severe hemodynamic instability. So what is your take on that? And what is your take on Dr. Prasanna's opinion of giving fluids and blood transfusions? Switch on your mic, please, Manish.
We have to depend upon history, clinical examination, and then laboratory values to see whether there is significant blood loss, which is causing hypotension or shock. So that the things that we take into consideration, the mechanism of injury, then the severity of the injury, then we see for the visible blood loss, then invisible blood loss by radiological investigations, and finally we have to take help of hemograms and other investigations.
In this patient, after the induction, there was hypotension. It was responding to fluids, and a phenylephrine infusion was used in order to avoid a lot of fluids. So would you agree with that strategy, or how do you want to proceed?
Yes, I definitely agree with this strategy. This is how it should do. It should
what is your fluid of choice in these patients?
Most of the time, normal saline.
All right. All right. Dr. Saurabh, your choice has changed recently because of a lot of trials which has come showing that balanced crystalloids are better and saline resuscitation, especially in a critically ill patient, is bad.
No, I'm still using normal saline.
All right.
Using normal saline.
Dr. Sudhir, your take on this, on what fluid to use in this scenario?
Yeah, any crystalloid is fine, but off late with the research, whatever information we are getting, massive fluid resuscitation of with normal saline is out. There is no doubt about it. And if anything, we are resuscitating more than 2 liters or so solution if available. If not, then ringer lactate would be a better fluid according to whatever we practice. Normal saline in massive resuscitation, no.
No. Okay.
That is definitely no.
Okay, all right. So in this scenario, would you consider giving a AED, start giving AED, or you just wait for the CT scan and then you start giving AED and you think it's not urgent? So when do you time your AED?
I didn't get you.
No, when do you time your anticonvulsant in this patient?
This patient, there are two things what literature says post-head injury. These patients are subjected to either an early seizures or a delayed seizure episode.
No, this patient has already got a seizure on scene.
Yeah, this patient has already got a seizure on the spot. So I would go ahead with seizure medication as early as possible.
As early as possible. Okay, right. You don't wait for the CT scan to start seizure medication. All right. So now I'll ask Dr. Rahul. Rahul, you got any message from the literature for us to share in these scenarios? Because different faculty have different ways of managing this scenario, but the goal was the same. to maintain hemodynamics. At no cost, you should allow hypertension. You should have a good control of the airway. And regarding intracranial pressure, yes, there's differences. Some would wait for a CT scan to be done before giving mannitol because they're worried about theoretically about the EDH getting expanded. So,
Ponniah. I want to add in this.
I'll go to Dr. Manish and come back to you, Dr. Rahul. Yes, Dr. Manish.
Yeah, regarding the giving mannitol before doing CT, it is absolutely okay to give mannitol before giving the CT. If you have facilities of CT scan and operating room available, because the point is that when herniation is occurring, you have to give some kind of brain relaxation.
Correct.
There is a theoretical risk of increase of EDH, but EDH will increase because brain shrinks. Okay. And even if there is EDH and if there is increase in EDH volume, you can take care of it in the operating theater, because if it is EDH, it has to be evacuated as soon as.
So traditionally, we have been taught in medical schools that EDH mannitol can expand. But what you say is because the CT scan is easily accessible, there is a herniation, the benefits outweigh the risk. Even if small proportion of patient has EDH, it's acceptable. Immediately we can shift them for the theater and do the definitive procedures.
Exactly.
I agree with you, Dr. Manish, but Dr. Prasanna has a different view. Okay, all right. So a lot of viewers have joined our chat also, and they are discussing what we are doing. Thank you, Dr. Nitin, Dr. Surya for coming, and Dr. Lalit for coming and joining in the chat. Okay. So, Dr. Rahul, I'll just come to you. So, you have some message for us from the literature in this. What we are doing is right. The literature is some other views.
Yeah. First of all, as per the initial resuscitation, the systolic blood pressure level has been recommended to be kept above 90 millimeters of mercury. Now, there has been an EPIC study, which is actually an evaluation of the Arizona State Trauma Registry, which showed that this arbitrary figure of 90 millimeter mercury is not suitable for all. That is, one size doesn't fit all. They showed that within a systolic blood pressure range starting from 49 till 119 millimeters of mercury, with each 10 millimeter drop in systolic blood pressure, there was an 18.8% increase in the mortality. So this 90 millimeter systolic pressure level should not be the target. It should be the BP management should be individualized. And
okay, Dr. Rahul, in this patient, how will you individualize? I have put a scenario. What will be your blood pressure target? I
would like to keep a systolic pressure at 100 and more than 110, between 110 and 120. In this based on the EPIC study, which is the largest evaluation of any trauma registry in the world. So rather than keeping it at 90.
No, because this patient has signs of herniation. Yeah. So ICP should be more than 20, maybe 40, 50, 60. Okay.
So definitely.
So is that enough? A systolic pressure of 110, or you want to aim for a mean of at least 90 or 100? Or you just want to leave whatever the BP which is higher, you will not treat the hypertension?
The thing is, again, I wouldn't target one level. That is, I would like to keep the systolic pressure more than 110. And there are other things which we can go ahead. As Dr. Manish said, in the event of an impending herniation, the literature says that you can go ahead and give either mannitol or your hypertonic saline.
Yes, quickly go to others and get their BP targets. Dr. Sudhir, your BP target?
That's according to literature, as Dr. Manish told.
In this patient?
In this patient, I would prefer to keep a mean of about 90 to 100. So because already there are signs
90, 100. Dr. Prasanna, you are laughing very, very loudly. So what is
signs of herniations is there? So we need to keep up the pressure head a little bit.
Sure, agreed. I agree with you, Dr. Prasanna. Mic, please. Yeah. Switch on your mic, Prasanna. Dr. Saurabh.
Hello. Yeah. In this scenario, I think the mean of 90 to 100 is okay, because we are not monitoring the ICP at present.
Okay.
So unless and until you monitor something, you can't.
90. Your mean is 90. Yeah. Dr. Prasanna, are you there? Yeah, Dr. Manish, what would be your
systolic blood pressure more than 110 and mean blood pressure more than 90?
More than 90. So I think most of them agree for a higher mean blood pressure, Dr. Rahul. So this is the thing. Anything else you have got from us?
Yeah.
Literature?
Second thing is about the drug, ketamine.
Yeah,
There was,
ketamine.
now there was a very good review which came out in 2014, and subsequently there have been few other reviews which have shown that ketamine, if administered with any other agent, like in combination with propofol, thiopentone, will not be deleterious. In fact, if you are facing a patient of hypotension or hemorrhagic shock, it's better to use ketamine in combination with one more agent, which can be either propofol, thiopentone, or thiopentone. So ketamine,
This already we have discussed, and we concluded that any drug you can use provided you maintain the hemodynamics. You maintain your goal, what you want. Yeah.
And third thing about the fluids is the recommendations and the literature says that it should be a non-glucose containing isotonic crystalloid should be your fluid of resuscitation.
Okay.
And the SAFE trial had already debunked that albumin, about the albumin. But recently, there have been 2 animal studies showing the efficacy of FFP in these patients. But these are 2 animal models. They showed that there was a reduction in the injury and the reduction in the volume and neuroprotection, but by Jin and colleagues and Imam and colleagues. But that is still experimental. So as of now, it is isotonic, non-glucose containing crystalloids. And coming to balanced crystalloids versus normal saline, well, there have been recent studies, but the evidence body is still not enough to favor balanced crystalloids over normal saline. So normal saline should be the fluid of choice in severe head trauma.
So what is your vasopressor of choice in this scenario in the initial phases?
Actually, again, the literature is unequivocal. It depends on your familiarity. Though many prefer norepinephrine, but again, the literature says that it should be the agent which you are familiar with. But norepinephrine has been used most oftenly in under such circumstances.
So how about a quick bolus of phenylephrine in this scenario? Because noradrenaline infusion takes a bit time.
Yeah, phenylephrine will just maintain your perfusion pressure head, so that can also be used. That's why the literature is very, very.
So what do you use commonly?
I use phenylephrine boluses till I can start a noradrenaline infusion.
All right, Dr. Prasanna, what do you use? And for the previous question also you can answer. Your mic is off, I believe. I'm not able to hear you. Yeah, Dr. Saurabh, what drug you use to maintain the blood pressure in these scenarios?
Most of the time noradrenaline, but till the noradrenaline infusion started, we use boluses of phenylephrine.
Okay. Dr. Sudhir, your protocol?
Sir, again, it's what you're familiar with. So, in your situation, your institution, what is the protocol followed? But personally, I would prefer phenylephrine initially to maintain, followed by noradrenaline infusion. That's always, and if you are familiar with use of phenylephrine, go with phenylephrine and then switch over to noradrenaline by the time it takes effect. Theoretically, there is a possibility that norepinephrine can cause reflex bradycardia when used initially. So that theoretical possibility is always there, but phenylephrine does not affect the heart rate as such.
Okay. So, although we have discussed in length, because this is an important phase of optimizing a head injury patient even before shifting to the CT scan. And always you should not forget that quickly getting a CT scan is very important in diagnosing an injury and proceeding further. But the phase of optimization is very, very important because it can affect the overall outcome of the patient. And a quick review from Dr. Sudhir, should you use any other drug in this scenario, or it's done just for CT scan? Would you like to use any other drug or any other intervention in this scenario, or just quickly shift the patient to the scan? With this scenario, the patient I presented.
I didn't get
using any neuroprotective drugs, any role of tranexamic acid at this scenario, because patient is bleeding profusely through the mouth and nose as well. So how do you manage that?
Tranexamic acid, iron, it's query. There is a lot of plus and minus about use of tranexamic acid in head injury. If it's base of skull fracture and larger bleeding, tranexamic acid is very query. With tranexamic acid is much more with more surgery in head injury. Head injury, I would prefer optimize the patient, take a CT scan, see what has happened, and maintain the blood pressure, oxygenation, and take him as early as possible to the OT and try to open up and release the pressure. Tranexamic acid later on, once bleeding starts, when the surgeon is decompressing small vessel bleeds, then tranexamic acid infusion at that point of time might help.
Okay. Dr. Saurabh, your opinion on tranexamic acid in a patient who has got skull bleeding, or in general in trauma and in head injury?
So we are not using tranexamic acid at all in head injury patients.
Dr. Prasanna?
Yeah, can you hear me now? Can you hear me now?
Yeah.
Yeah, sorry for that. There are some mic issue. Corrected it.
No problem.
Yeah. Tranexamic acid is a relatively harmless drug you can use. There is absolutely no problem in that.
Okay.
The dose what you use, people have used from 10 milligram per kg bolus to nearly 100 milligram, 50 milligram per kg also. So the higher the dose you may use, you may end up in renal failure or something. 10 milligram per kg bolus, 10 to 20 milligram per kg
But Dr.
bolus.
Prasanna, when do you dose it? Because our aim is to quickly get a CT scan as quickly as possible.
Yeah.
Should administering a drug like tranexamic acid, or just for the sake of giving some neuroprotection, should it delay shifting the patient to the CT scan?
No, absolutely not. If you can simultaneously do that, you have the manpower available, you do it. Correct. Otherwise, you can do it later also. You can.
So how do you stop the oropharyngeal bleeding in this scenario? Usually you pack the oropharynx. How do you do that? You have different ways of doing that. How do you advise your ear?
Yeah, we have to see this is an emergency scenario, and there is a pupil which is one side dilated.
Correct.
So you can't be too much worried about that. Pack it whichever way efficiently is possible. Use either a gauze piece, big pads, or a ribbon gauze may not be sufficient if it's a torrential bleeding. You can put a bigger gauze pieces, keep the count of the gauze piece, and shift the patient quickly to the CT scan facility.
Do you have the habit of inflating the Foley's catheter inside the nasopharynx and things like that?
No, I have not done actually. I have not done.
Okay.
But if somebody is available, okay, I would.
You routinely put a Ryle's tube to decompress the stomach in this scenario?
No, as of now, I will not do. First, for priority will be to get a CT scan because of the pupils, unequal pupils.
Yeah, Dr. Sudhir, your protocols in this bleeding scenario through mouth and nose, oropharyngeal bleeding?
The option for resuscitation in this way. So the earlier you shift the patient to the CT scan, to the operation theater post CT scan, that is better. Stabilize during transition, and whatever is available, like Prasanna told, pack with whatever your protocol is, and then shift the patient to the OT where resuscitation can be properly maintained and monitored. Yeah.
All right, agreed. So getting a CT scan early is the key. It's a neurological emergency, especially when the patient's pupils is dilated, one side pupil is dilated, and this patient might need an emergency surgery. Okay, Dr. Sudhir, regarding the CT protocol, what protocol you follow? You do a pan CT scan of trauma series of the entire head to pelvis, or how do you proceed in this scenario? With contrast, without contrast?
Yeah, in our situation, in our ED, which is quite very busy ED, and we don't have any control, our protocol is they do a plain CT as early as possible, no whole body, and our situation is they assess the patient to see whether any obvious long bone or abdominal injuries are present or not. If there is no obvious long bone or abdominal thoracic injuries, straight away go and take a plain CT scan and proceed with the resuscitation.
Okay, last. Dr. Prasanna, what is your protocol? Which is better, or what do you follow, and what is the literature? What will be the ideal thing? Sometimes we cannot follow an ideal thing in especially a ER with high number of patients.
Yeah. It entirely based on my history and the clinical examination findings. If I am suspecting that there is an intra-abdominal bleed or something, or I have done a fast scan, I know that some bleed is there, some liver laceration, I want to rule out, then I will do a whole body. Otherwise, it will be essentially restricted to head and CT scan of the cervical spine, because I have not assessed. We have intubated him in the emergency. So I will do a head and CT scan of the cervical spine to see any.
Sometimes if you miss some intravenous injuries here,
yeah,
it can cause problems intraoperatively, where you will not know control over it and you will not know what's happening exactly.
True. But if
what would be ideal if everything is possible? Would you go for a pan CT or still you will not go?
Still, I feel it's a overkill. Because if that magnitude of any
because there are some trauma centers in the world where when the patient comes, immediately they are scanned at the ER entrance itself, even before primary, secondary service.
Yeah. So what I'm telling, if any of that clinical scenario is there, which can be clinically significant later intraoperatively or something, it would manifest in some way, right, in the preoperative examination and during shifting.
But don't you think it's a very complex scenario, a polytrauma case, where it's very difficult to pick up a specific finding?
Yeah.
The specific region.
I know that is true, but I don't think whole body CT scan or anything is going to reveal you much.
Saurabh is raising his hand. I'll go to him. Yeah, Dr. Saurabh.
What we generally do is trauma protocol is actually very clear. If you go for a CT scan, head CT scan is normal, or head CT scan should be given the preference, and then you do a fast scan. If a fast scan is positive and the patient is hemodynamically unstable, go for a CT scan, and sometimes you need to go for a laparotomy straight away. But if the fast scan is negative and your patient is unstable, you have to go for a CT abdomen at that time. So you have to do formalize a protocol in your
okay, I think we are too much digging in this trauma, and we have to quickly go for a decompressive craniectomy.
In this
so I think I myself have a lot of difference in opinion in this particular topic, so we'll discuss at a later date. Now quickly, so this patient CT scan was done. I'll just share my screen to show you the CT scan. All right, I hope you're able to see my screen. So this patient CT brain was done. So this is the CT brain. Okay, so there is a SDH on the left side with fully phased assistance and a lot of midline shift. Right.
Yeah.
So this patient is posted for an emergency decompressive craniectomy of the left side. So how do you proceed from here, Dr. Sudhir?
Yeah, the patient is already intubated in the ER and he's been transferred. The moment the patient is transferred to the operation.
By the way, a small information.
Yeah.
This patient has been brought by the ambulance, and we don't know who their relatives are. We don't know who the patient is. So this is the scenario. But the surgeon, the team, trauma team, the neurointensivist, everybody believes that it is a ultra rapid emergency, and the patient does not even go to the ICU. He has to go directly to the operation theater. Yeah. You agree with that, or you want to buy some time for the relatives to come, and you want to buy some time to optimize the patient in the ICU?
No, this patient needs surgery, so he has to go to the OR as early as possible.
So how do you tackle this logistic? The patient is not known to anybody, and he has got a mobile phone where some numbers are there, his parents' numbers are there. So how do you go with the consent in this case? What is the
in this case, the consent? There are two things what we do generally in our ER. Now, when patient is unknown, many times we don't know who is the patient for more than 4 or 5 days after surgery. Also, when a situation like this arises, there are two things what we commonly do. One, a police would have accompanied the patient to the hospital. One, second, if you try to get some relatives at the earliest, telephonic consent or whatever it is, if possible, you can take it. Otherwise, the police who has come with him, so consent can be taken for him for an emergency surgery. Sometimes what we do is, if nobody is available, we take consent from our medical superintendent. MS, we call the MS, we tell him the situation, it's like this, we are not able to trace anybody, and take consent from the MS, proceed with the surgery and do other things later. So that's what we do.
So the point is very clear. You need not wait for the attenders or relatives. If it is an emergency as deemed by 2 or more doctors, you can go ahead with the head of the institution consenting together, then you can proceed to the surgery. Is that right, Dr. Saurabh? You will do the same thing in the
We do
private setup as well, because it was a government setup is working.
No. Yes, we do the same. We tried contacting the relatives, but if they are not available, we take the consent of the medical superintendent.
Suppose you're able to contact the relative, he's on a telephone, he doesn't understand the scenario. He's saying that, please wait till I come.
We will ask the time, what time he is going to take. If it is within 15, 20 minutes, 30 minutes, then it's probably okay. We'll give a dose of decongestant and wait for till that time. If it's more than that, we'll straight away go for a surgery. We're not going to wait.
Dr. Prasanna, yeah.
No, there is no point of contacting the relative, at least for as far as our setup is concerned. That work will be done by the police fellow. It is his job to contact them. Straight away go to, you need not even call the MS. MS will not be available all the time. It's the casualty medical officer who is the doctor available there. He is the supreme as far as the emergency are concerned, who is working there. The main CMO who is the head of the emergency. If he signs, if he gives the consent, that's it. Take the patient to the OT.
So one doctor consent is enough, or it's like two doctors has to give a consent or something like that?
No, I think you are the treating physician, you know, and the casualty medical officer is the one who has received the patient. Once it's the MLC, it comes under him along with the police. So it's a police job who will contact. You take the patient for the surgery along with his consent.
Dr. Manish, do you do the same thing, or what is your protocol?
Yeah, exactly. It is the same thing. And I also want to add one thing, that till now, there is not even a single case against such an emergency surgery.
Okay. So nobody is going to find fault in such a strategy.
Yes.
In an emergency scenario. Okay, all right. So this patient, everybody agreed that has to be directly shifted to the operation theater for decompressive craniectomy. So we just discussed the practical points of decompressive craniectomy in this scenario. So how do you proceed, Dr. Sudhir, from here onward? The patient is shifted to the operation theater. So what would be your message to the blood bank?
Two things are important. As soon as the patient comes into the casualty, whichever casualty it is, the first protocol is take the blood sample and send it to the blood bank and to the lab for investigations. Do not wait for anything else. One, and the blood bank, if it's a very good blood bank which is catering for a big trauma institute, then you need not worry. They will have stock of everything available. Sometimes what happens we also had a situation when the trauma is overwhelming and the number of patients are too much. You might not get blood and blood products of that particular match. So there was a time when at certain point we used to keep O negative blood in the OT, so that in case there is a requirement and your blood batch is not, or it's taking time and you require blood, we could go. We used to use O negative as a rescue transfusion, and then later on as blood comes, we go ahead with the transfusion.
It's a rescue transfusion, or as a trauma protocol itself, you'll have a trauma pack of namely 6 PRBCs with FFP and platelet.
That's not. That's not as protocol. For it as a protocol, we used to have some 3 or 4 units of O negative in the OT in case we had to buy some time for the correct match to come. Otherwise, the blood bank, if it's a good blood bank, they will have a stock, and the first thing you need to do is as soon as the patient comes to the.
So in this case, what would be your message to the blood bank?
The blood bank, as soon as the blood is reached, they would have.
How many units you would ask for?
Depends, at least 3 to 4 units of PRBCs with 4 to 5 units of plasma and platelets to be ready.
All right. Minimum. So all the products, yeah. Dr. Prasanna, what would you do in this scenario?
Same. There are 3 types of tests which are done for grouping and after that cross matching. So the third one, if you want to do that check for all the antibodies and other, it takes a lot of time, maybe around 45 minutes to 1 hour. So if you tell the blood bank it is urgent, they initiate a transfusion protocol.
Because by the time they remove the bone flap and the bleeding starts,
so they will
be 40 minutes.
So they will provide if this one is there, either a group specific or O positive or O negative, whichever is available that time, I will take and transfuse it.
All right, Dr. Manish, usually how many units you would ask for the blood bank to keep ready in this scenario?
Keep ready at least 4 units of PRBC. Don't get FFP or platelet matched, because there is no point in matching them. The blood, most of the times in an emergency situation, they just do type and screen, which has a sensitivity of more than 99.9%. That is good enough for me. Cross match is rarely required in emergency situations because it takes times. If you have time, then you can cross match also. But type and screen, the modern way how they screen the blood, it is as good as doing cross match.
All right. So now I will share my screen. The problem is that when we did the pan CT scan of this patient had a pneumothorax as well on the right side. So how do you proceed in this? Are you able to see my screen?
Yeah.
So there was a pneumothorax.
Background noise coming from somewhere.
Yeah, there was a pneumothorax in the right side. So how do you proceed in this scenario? Dr. Manish, would you place a ICD before proceeding, or pneumothorax so you can accept it?
Yes. I would place an ICD. When the patient is taken to probably from the city itself,
Ponniah, there is a background noise.
Too much of background noise.
CT scan is very bad, so that immediately the patient has to be taken for a CT scan to the OT, and in the operation theater they can put an ICD along with when they prepare the patient for surgery.
All right. So I'll go to Dr. Sudhir. Dr. Sudhir.
Yes, sir.
So there was some pneumothorax which was detected in the pan CT scan. So Dr. Manish said you should place an ICD, however small the pneumothorax is. So what is your take on that?
There is no doubt about it. If there is a pneumothorax, place an ICD. That is, there is no question, because when you go take the patient to the OT and you are subjecting him to positive pressure ventilation, that is going to increase. There is no doubt. So given a choice, first thing to be done is put a chest tube and come out.
All right. So this patient chest tube was placed and you were shifted to the operation theater. And from here onwards, what would you do? Just enumerate what happens in the operation theater.
In our setup, as soon as the patient comes, the patient is now the patient is in a relatively stable condition. The blood bank has been informed about blood products and all. So the patient comes in, and whether to start give an induction agent depends how the patient is when you receive him. So I would still go ahead and give a small dose of induction agent with volatile anesthetic, muscle relaxant, and then go ahead and start the surgery as early as possible. Take what we do is we take 2 big bore IV lines as early as possible, and an arterial line.
All right.
So once the patient is
central line before the surgery.
Not in all cases. Not in all cases, and
in this case.
In case there is a polytrauma, there is, as you told, there is a pneumothorax in this patient, and there is profuse nasal bleed, and with the ultrasound guidance, central vein access is as easy now. So if you do not find 2 big bore IV lines at the earliest, so go ahead and put a central line. Do not waste time.
Where? Which side?
If you're always whichever side the thoracic tube is. If there is a pneumothorax and you put a thoracic tube, you put the central line in that side and come on. That would be it.
So you see, even if you put a central line in this patient, it's going to take at least 10 minutes, isn't it, for your preparation and putting things together? Don't you think it's a waste of time? That is
what I told. If you have 2 big bore IV lines and you are able to test, then don't worry. If you cannot access 2 big bore IV lines, then it's still worth taking a central line.
All right. Dr. Prasanna, how do you proceed in this scenario in the initial part in the OT?
Yeah, very much same one. So generally, to 2 peripheral large bore cannula and start the surgery.
So suppose there is a difficulty in large bore cannula, a lot of swelling, a lot of fracture in both the hands. Would you go with the lower limb cannula?
Yeah, definitely. There is no worry about where I am putting as far as resuscitation is concerned. In the intraoperative period, post-op, we can manage all those things.
Right.
Before shifting the
patient. How about accessing the femoral line? Because there was a good article on the emergency medicine saying that don't forget the femoral access. Because it is easily accessible. We can allow the surgeon to prepare their head. Meanwhile, you can quickly put it, and in the post-operative, you can remove it and go for a proper central line. So what is your take on that?
you can put if you are comfortable. Nowadays, less and less femoral is being used. There was a time when people were afraid for IJV and subclavian. So femoral was the most commonly practiced route. Nowadays, nobody practices.
No, I'm not talking about routine practice. In this emergency scenario, which is where the time is everything, as quickly as possible, the bone flap has to come out.
So if you fail to secure a femoral as early as quickly as possible, if the hypotension happens, that is more deleterious than what it is. So I would rather wait for a central line in such scenarios, or you take a 2 peripheral lines and start. I don't think
no question about 2 peripheral lines. When that scenario is not available, when you have difficulties in getting peripheral line access, there is a problem. So, only that scenario I'm discussing.
If you see,
so there is no regular central line. It's clear. Everybody is accepted that.
If you ask me,
what is the rescue for you?
If you ask me, I will take 3 minutes, 2 to 3 minutes for a subclavian, and I may take 15 minutes for a femoral. Rather, I would take the 2 to 3 minute chance, and you take other ICP measures of reducing ICP by that time and put a femoral. Because if you do not have the sufficient lines to transfuse or give crystalloids, you are going to land up in trouble. I don't think femoral I'll go for that. Because sometimes you find hours together, we are not getting femoral. At least if you ask me.
Dr. Saurabh.
Yeah, I will also prefer a central line because we are more comfortable with putting an IGV or a subclavian, and we'll put it in rather than 5 minutes rather than going for a femoral, because femoral is generally out of touch for now.
So this is only in do it regularly or only in special scenarios?
After you, if you're not able to find those big cannulas, you may find it anywhere. You're comfortable with femoral, put a femoral.
All right. Dr. Manish?
If I have an ultrasound on the bedside, then I may try femoral, but most of the times I put IJV or subclavian in case I do not have IJV, because it takes, as Prasanna and Saurabh said, less than 3 or probably 4 minutes.
Okay, right. Okay, Dr. Sudhir, so you said that arterial line is a must, isn't it?
I would prefer, if given a choice and you have time, you have a facility, place an arterial line that will give a reasonably good guide of your blood pressure. You can monitor and maintain your CPP. So,
my question is, it is your preference or it is a mandatory thing?
No, it is not a mandate as such, but I would prefer to have a arterial line in place in as many cases as possible.
Dr. Prasanna, you are laughing.
No, it is mandatory, but I would not stop the surgery for that. Surgery will start, I will secure it anywhere in the world. Now we can put a femoral artery also here, no problem. But I would need arterial line, particularly for the SDH.
Okay, I made Rahul wait for a long time. Okay, I'll go to Dr. Rahul. Yeah, so you concur with all these views. What would be your practice, and what is the literature saying? Is there any literature on that?
Literature says very specifically that evacuation of the acute SDH takes priority over everything else. So arterial line, taking arterial line is recommended, but waiting for a central line is not recommended at all. But in case you are not able to take 2 peripheral lines, there's been some literature in EM, as you correctly stated, that you can go for a femoral line while the surgeon would have taken control of the head, because they will not give you any time. Once the patient reaches the OT, patient will immediately take control, and evacuation of acute SDH is the topmost priority. So the literature recommends going ahead with the invasive arterial line, but literature doesn't recommend putting in a central line. But EM, literature in emergency medicine, says that if you cannot get a peripheral IV access, you can go ahead and put in a femoral line till the surgeon has already started the procedure.
Okay, now I'll go to Dr. Sudhir and again re-emphasize on the things which we have to do to reduce the intracranial pressure. If I remember correctly, you said that your anesthetic technique would include an inhalation-based technique.
No, not necessarily. An IV, it depends on the patient. If patient is already too comatose.
No, in this patient, is a cold brain situation. Would you prefer an inhalation-based technique, because it's not it's going to be detrimental in terms of ICP?
Not necessarily. So always, not all the agents are detrimental for ICP. Isoflurane is reasonably safe. And I would say don't go for a completely volatile based technique. A combination of volatile and IV technique.
And because if I remember correctly, this patient is already on a propofol infusion as a part of a code brain protocol. That because his pupil is still dilated, they have started propofol and the patient is on propofol infusion.
Yeah, if the patient is on propofol infusion, there is no need to worry. Straight away give relaxant and then proceed with the surgery. In case if the patient is not on any infusion of propofol or anything else, then you go ahead and combination of propofol and volatile anesthetic could be.
So you use opiates as well. So what is your take on that? What is there any will there be any pain for this patient, a comatose patient?
Pain is again, it's still a controversy. Any given any situation, you always cover an analgesic. That is what I follow. Some dose of fentanyl, or if you, as like the Western world, if you have remifentanil, nothing like that. So if you don't have remifentanil, the fentanyl is reasonably good. You have to give it. That's what I feel.
Okay. So Dr. Prasanna, your take on this about pain in this patient and how do you dose fentanyl? What will be your anesthetic technique? Do you believe that inhalation should never be used in this scenario because already patient has got herniated, so better you go with only a TIVA?
Because as long as the head injury patients are concerned, there are no studies. Okay, whether it is TIVA or the inhalational agent.
That's the exact reason we are discussing it today.
Yeah,
it's only about the practical aspects of how we are managing.
Practically it all depends. In this patient particularly, you are anticipating a raised ICP. There is a raised ICP.
Now, this patient already it's proven because we have done a CT scan. We have not even waited for the consent. We just shifted the patient to the theater.
The biggest advantage for inhalational is that you have the titrability. Suppose once the bone flap is removed, you know that.
I'll just put a point like this. Should you give anesthesia for this patient? What is the point? He is already comatose.
No, I will give anesthesia. Just because he is not able to get up and slap you, you just can't say I will not give you anesthesia. Same is with analgesia. So, and one of the important aspect of anesthesia is barring the adrenergic response also, not only the analgesia. So you need analgesics and you need anesthetic agents also. Okay.
So what is the final take on inhalation versus continuing with TIVA?
Based on the experiences of the elective cases where there is a raised ICP of tumors or something where we feel TIVA is definitely better for the inhalational agent. In this scenario, I would rather
TIVA is better, right?
Yeah, TIVA is better, and you wait for the results. We have done a study; it will be soon out.
Right, Dr. Manish.
Analgesia patient will the pain is perception of noxious stimulation. Okay, so that because the patient is not conscious, so there is no point in saying that patient might be feeling pain. In the same way, the purpose of anesthesia is to make patient remember or to produce amnesia during the surgery, and because the patient is already unconscious, so that this also goes away. So the target of anesthesia regime in these patients is not to make him hypnotic or not to make him pain-free, but to control cerebro and cardiovascularly stable patient. So how do you do it? It is a different thing. I give opioids because they give me better hemodynamic stability. I use IV agents because they give me better cerebrovascular stability. So that I use fentanyl along with propofol titrated to the swelling of the brain and other parameters.
So anesthetic goals and anesthetic management is nothing but extension of management of refractory ICP and herniation.
Very true.
That's it. So your goals, the traditional anesthetic goals, are less significant in this patient. That is what you mean to say.
Yes.
Right.
Exactly.
Dr. Saurabh, you agree with that?
Yeah. So in this scenario, actually the anesthetic drug act as a therapeutic agents rather than acting as an anesthetic agents. Now, how you juggle with them is a different take. You might have a different take on it. So I use both. I use a mixture of both. So I have a sevoflurane with a less than 0.5 MAC and generally has an increased dose of propofol in that scenario and maintain blood pressure and hemodynamics accordingly. I do use fentanyl to maintain the cardiovascular stability, as Manish has already pointed out.
Okay, so we have taken two peripheral lines. So what would you do the two peripheral lines? Both the lines you connect the fluids, what is the extension of the tubing you use, because you're not accessible to
So
distal
we
port
are
easily. So how do you do the practical tips? Yeah.
So we are using extension lines in both the both the IV lines, and we use one a normal drip set and one a BT when it's connected to the blood transfusion set. This is the practical scenario, practical things which we used to do, and we connect noradrenaline infusion to one. We usually connect a noradrenaline infusion, and at is a 0.1 ml per hour. It's just going and flowing. Whenever I need it, you just have to increase the dose with that scenario. And in one cannula, I have connected the propofol infusion. So it's like that. This is the practical things which we are doing, and on with inhalation and boluses of fentanyl. That's what we are doing.
Dr. Prasanna, how do you just give some practical tips for the?
Yeah, same. We are using 150 centimeter extensions for any line which is connected, whether it's a peripheral line or central line, because that will you are in the leg end, and it will give you much more flexibility. And as far as possible, a 16 gauge line, one at least I would aim for a 16 gauge, where I can transfuse much faster. In the large, you can go for 16 or 14 or some 18 also, we classify it as a large.
Is there any concerns of giving noradrenaline through a peripheral line?
Yeah, they are there. But in this scenario, as far as the intraoperative period is concerned, it is very much okay. And since we are anesthesiologists and we are working in the ICU, we feel day in and day out, vasopressors and anatropes are used in peripheral lines in all medicine wards. So it is not that just because you are infusing a inotrope or vasopressor infusion, you need to have a central line all the time. It is desirable to have, but in the intraoperative period, you can transfuse. But where you connect this vasopressor becomes a very important step.
Yes.
If you connect in the extension between three-way and you flush it with 10 ml saline, you'll be flushing a big bunch of vasopressor. So preferably you connect a three-way at the site of the venous cannula, and there you connect the vasopressor and the inner running IV.
Very important practical tips. You have to connect the vasopressor as distally as possible.
Yeah,
three-way.
True.
Sure that the line is always running, so that the vasopressor does not concentrate even in a 10 centimeter extension, so that you may purge vasopressor bolus.
That is the most common mistake we do as a resident. I think all of us have done. So
the most important thing is that you don't worry about a peripheral line, giving vasopressor through a peripheral line, because in this scenario, even a thrombophlebitis, if it happens, can be managed later on, but it's a life-threatening scenario though, so that you can proceed with whatever you want. And everybody said that you have to always be ready with the vasopressor. Don't search for vasopressor when hypotension happens.
Used to connect it.
These are all the very important practical tips, and really appreciate that. Okay, so I'll go to Dr. Sudhir. I think he will also agree with all the
Rahul wants to make some point.
Yeah, Dr. Rahul, you are a literature man, so you'll say what is in the literature. Yeah, correct.
Yeah, again, now here, once the patient has been induced and the surgery is underway, here I would go ahead and give tranexamic acid, because again, a controversial topic, but literature actually there was a nested trial within the Craniectomy trial, which showed that though tranexamic acid reduced the volume of the intracerebral bleed, it was not significant. Then there was another trial from Thailand, randomized controlled trial, which again showed that administration of tranexamic acid reduced the volume of the bleed. But again, it was not statistically significant. But in a meta-analysis, where the results from both the trials were pooled, it showed that the reduction in the volume was significant. Now the Craniectomy trial is underway, which should, I think, solve this dilemma. But based on that meta-analysis, which has been shown that the reduction in the volume, intracerebral volume, is significant, I would go ahead and at this stage, give 1 gram tranexamic acid over 10 minutes bolus.
All right. So is there any literature on anesthetic techniques in this kind of scenario, different anesthetic technique?
Again, I would abide by this. There's a paucity of literature showing the efficacy or beneficial effect of one technique over the other. It finally boils down to what you are familiar with or what you have more worked. and a balanced approach would be more appropriate. Yeah, I would just bring in one good study by our own Dr. Deepak Sharma. It was a retrospective study done in Harborview Hospital, where he found out that the incidence of intraop hypotension in these patients was near 100%, but the anesthesia technique or anesthesia drug was not the causative agent. It was the presence of multiple lesions on the CT, the SDH, and the thickness of the CT lesion, and the duration of surgery, which were the 4 contributing factors. So the belief that the using of inhalationals would lead to more hemodynamic instability is unfounded. If you are using it in less than 1 mAh, and we have got a good body of evidence with isoflurane, which has been even shown to have neuroprotective mechanism of effects in these patients. So if you're using inhalationals, use it in less than 1 mAh, and you can, as
So
Dr.
Dr. Rahul, I'll just quickly ask a question regarding this inhalation agent.
Yeah.
See, in a practical scenario, even in elective cases, when you are using inhalation agent, suppose there is a brain bulge, what do you do?
I will stop the inhalation agent and switch completely to propofol.
Right. So you stop, and in this scenario, the brain is supposed to bulge, or already there is a rise in intracranial pressure. Then here, why do you want to use inhalation agent?
Not in.
Because already the scan is showing a midline shift. There is an SDH. One pupil is dilated. Then why do you want to use it? During elective case, when the brain is bulging, you are stopping it. And here already you know by imaging that this is a bad scenario within the brain. Then why do you want to use inhalation agent? And why can't you go with the propofol, where you'd go in elective scenario, which you think that it is better cerebral hemodynamic effects?
I actually use propofol only. I just told what the literature says, that inhalationals you cannot hold. We all are using propofol. All neurosurgeons are more versed with propofol in such circumstances. And I'm
so if you want to advise your resident, suppose your resident calls you and saying that there is a case, and what would you advise him? What
propofol.
Thank you. Dr. Prasanna,
the answer for this question is your next question itself. What is going to come, I know. So inhalational agents are going to give a good titratability. You can take them off anytime when you want, when hypotension happens. Whereas it is not the case with the TIVA. We need to be very careful. We cannot just rule out inhalational agent even in a traumatic brain injury, because when you use a TIVA, invariably your use of vasopressor is going to be very high. That means incidence of hypotension is high. So whereas the inhalational agents are going to give you that margin of safety. So we cannot just rule them out that they are not useful.
No, that is a good discussion happening in our live chat as well. Some people believe that other way, exactly opposite what you say. They say that inhalation agents produces more hemodynamic instability than in this scenario.
I agree with this. The IV agent goes less.
You agree with whom?
With you.
Okay.
The IV agent.
No.
The IV agents give us a better hemodynamic stability rather than IV agents. Inhalation agent. Inhalation agent causes profound hypotension.
You should say that you disagree with Prasanna.
Yes, I do.
No.
For the first time.
No.
Yes, Prasanna, I'll give you a chance also to defend you.
No, it's not defend you. Use it, you'll come to know. You are using daily in routine cases also. You know that because once it's always the agent which can go fast out. That's all. When you cut off the agent and increase the flows, your inhalation agents are off when you have a hypotension. Definitely, it is not going to happen with either you are giving a TIVA, which is very less, like a 5 ml per kg, 5 ml per hour of propofol, then it's okay. If you are giving a 75 to 100 mics per kg per minute, you take my words, it will be difficult to control the hypotension when it happens. If you are giving a very less dose, which is insignificant as such to the body, then it's okay. But if you compare one man,
no.
In this scenario, happen, would you still persist with the anesthetic agent, or will completely shut down the anesthetic agent, or decrease the concentration? How do you proceed?
Precisely, that's my answer. That shutting down the anesthetic agent is faster with inhalational as compared to the TIVA. You can shut off the infusion. You cannot shut off the agent which is inside the body. It takes time to get out, right? Okay. But in the as far as the inhalation is concerned, they are out in 2 minutes, 1 minute. Once you increase the flows and switch off the agent, they are out. So that is what is the easy titratability what inhalation our agents are going to give us.
But you feel that inhalation agents are safe by going by because I don't have a literature to prove, but safe going by common sense.
Yeah, my common sense says propofol, but my inner heart, if I am standing in the case throughout, still I may go for isoflurane. It's very difficult to answer that. Yeah.
Prasanna, I will answer you.
Manish will answer. Yeah. Manish.
No, I want to make a comment that you said that once you switch off the inhalation agents, that will be out.
Yes.
But the problem is that whenever there is profound hypertension, there is reduced cardiac output also. So that even though you may feel that exhaled gases may contain less of the inhalation agent, but in the body there will be high concentration of inhalation agent. Inhalation agents by pharmacokinetics only will take a longer time to be eliminated when there is hypotension, because propofol will get redistributed and will be metabolized. So that if you use judiciously the judicious doses of propofol, you can control the hemodynamics in a better way. You do not have to stick to 10, 8, 6 or any other regime or any other fixed dose module.
So that is what is my point, Manish. If you are using a 0.2 mac of sevoflurane, 0.2, 0.3 mac of sevoflurane and 5 or 10 ml per hour of propofol, which comes to 25 mics per kg per minute, hardly makes a difference. But if you are giving a 1 mac of or 0.8 mac of isoflurane and 100 mics per kg per minute of propofol, that is where this scenario I am discussing. So when we are giving under a very low dose, that is okay.
No, it is not very low dose. I again said in the beginning that the goal of the anesthesia is not to provide the hypnosis, but is to provide hemodynamic and cerebrodynamic stability, so that you titrate the dose likewise, and there will be lesser incidence of hemorrhage. The most times the hypotension occurs when the decompressive cranectomy is done, when the bone flap is removed and all of the sudden the ICP is relieved. At that time the hypotension occurs, and that's why exactly all of you have said that noradrenaline infusion has to be ready. So many times there is hypertension during the procedure, but as soon as the bone flap is removed, there is severe hypotension. So you have to be prepared for that also.
So very important points Dr. Manish and Dr. Prasanna has brought out. So you have to be always ready with the vasopressor. Post decompression, 100% of the times, as Dr. Rahul said, there is hypotension, and you have to manage hypotension very effectively. And maintaining the hemodynamic stability is the foremost goal in these patients, because regarding as per the anesthetic techniques, we have a huge variation in practice and in entirely different spectrum, and common sense dictate something and we do something, but definitely we don't know what is happening inside an injured brain. How an injured brain is going to react to an anesthetic is entirely will be different than what is a common brain. What is the cerebrovascular reactivity? We don't know anything about that. So here, as rightly Dr. Manish said, the goals are entirely different. At no cost, we have to lose control over our hemodynamic stability. That should be the main goal. And the common anesthetic goals take a back seat in this scenario. Okay, Dr. Sudhir, you agree with that? And
100%, there is no question. If you are the lone anesthetist and you have a head injury in the night, so it's a scary situation. You always keep your noradrenaline flow as distal as possible from extension, as nearer to the IV line as possible, and keep it running. And then as soon as the decompression is done, if there is, as you told, there will be hypotension, you can step up the dose of noradrenaline. And again, isoflurane, again, I told you, I prefer having a combination technique of both propofol and isoflurane. And isoflurane used less than 1 mac is still safe. Anything more than 1 mac, again, is still questionable. Less than 1 mac of isoflurane is still safe. It can still be used.
Okay, right. So regarding anesthetic technique, we can never reach a consensus, but everybody is very clear on one thing. That is the goal. You have to maintain absolutely the hemodynamic stability. You have to expect that the hemodynamics are going to be unstable. Be prepared for that and maintain the hemodynamic stability. And Doctor, to everybody, let me share my screen and show what happened in one such patient. That once the surgery was on, sorry. Okay, so once a surgery was on, patient ICD was inserted, as you rightly said, and once the surgery was going on, the patient was desaturating, and there was hypotension with tachycardia. So, can you see the monitor, Dr. Manish?
Yes.
Can you all see the monitor screen?
Yeah. Yes.
Yeah.
Okay. So this is exactly the monitor screen during that scenario. So by this time, the bone flap is being raised. It's not even completely out, right? It's not a post-decompression hypertension, maybe. So how do you proceed with this scenario? Dr. Sudhir.
Yeah. The ICD is in, and
ICD is already in. There is a slight increase in peak airway pressure. As I told you previously, the patient had a profuse oropharyngeal nasal bleed. Intraoperatively, there is a troubleshoot. Namely, is desaturating, requiring increased oxygen concentration. You have to really put him on 100%. And then you can feel a resistance in your bag, and the BP is also dropping. This is a scenario. So how do you manage? As you rightly pointed out, this thing, at times when you're doing a head injury, you'll be single-handed. You'll not have anybody. Because it's an emergency situation, maybe in the night or in the late evening, especially when you're left alone. So just quick practical tips on how to manage such troubleshoots.
Yeah, the first things first, always see if any technical problems are there. See your circuits, your whether ventilation is all right, your machine is all right. So once you troubleshoot all these things quickly, then look for other reasons what could have gone wrong. So one thing is your ICD placed to see whether the ICD is properly draining or not. Most commonly, that is the problem which happens. So if the ICD is draining properly, there should not be a problem of desaturation. If desaturation is occurring, then troubleshoot other things first and then look for the final cause.
So what do you do step by step, please?
Step by step, I'll check the corrections, I'll check the machine, everything is fine. Then you take over the hand ventilate, see or auscultate, see what's happening. Whether a patient would have aspirated, you'll never know.
Most of the time, the patients are fully covered, isn't it? We are left in the foot end.
Yeah, that's okay. But you can still auscultate and see what's happening in the lung. If your entry is all right, then fine. If your entry is not all right, then we'll have to look for what are the causes for air entry. One thing is that aspiration, is one possibility. Patient is breathing through nose, mouth. Aspiration is one thing, slowly raising airway pressure. And most commonly, what happens in head injury, especially if you're operating in children, airway kink in the tube is the most common thing which happens. So because a lot head will be covered, so your tube kinking somewhere is one most common reason of this raise in airway pressure and decreasing
saturation. During drilling and cutting the bone, the surgeons can and the nurses who are assisting can just cause a kink in the ET tube.
Yeah.
Okay, Dr. Prasanna, how do you troubleshoot this scenario?
Yeah, very
how do you solve this troubleshoot?
Yeah, first is look for any kink in the tube. Check with the bag ventilation, whether you see whether you had any aspiration. Check whether the machine is completely working. Then check for the ICD, whether ICD is moving or not. And then if all these things are done and hypotension and raised airway pressure, suspect the other side pneumothorax also. Get the ultrasound, see on the same, both the sides.
So you hold the surgery for a while, get the ultrasound, do all these things. How do you proceed? Practical tips. Practically, what do you do?
Yeah, you can continue. You can do the ultrasound from the leg side. There is no problem. You need not go there.
Okay.
You can do simultaneously. If there is a raised airway pressure, he is going to have trouble. Okay. So there is no way. So it has to be controlled. And
so
once
how about a simple suctioning, putting a suction tube into the ETNC if some secretions comes out?
So if when I say check for the kinking, it includes the suction also.
Okay.
Physical kinking and conditions. And then go for the ultrasound, whether it's opposite side pneumothorax also are known to happen. We may have missed in the pre-op in a hurry to take
I said to you it was a CT scan. It's very sensitive to pneumothorax, isn't it? So how often you miss a pneumothorax in the CT scan?
No. It is not like that. The pneumothorax it still can occur in the intraoperative period on the
Agreed. But what is the chance in this patient in this scenario? In this scenario, what is the chance?
In a trauma scenario, everything is possible. In a trauma scenario, everything is possible.
All right, Dr. Manish, I'll go to you. So this patient's suction was done. There was some blood secretions. but I couldn't say that actually it improved, suction improved. But he required higher oxygenation, some lung recruitment maneuvers was done. So do you do that routinely, Dr. Manish, inflating with high airway pressure and recruiting the lung?
No, not in this scenario, because there is already a pneumothorax. There is risk of possible pneumothorax on the other side.
Okay.
So giving large volume and high pressure breath may cause further deterioration.
And if saturation is not improving with your suctioning with all the measures, then what do you do?
If all the mechanical causes are ruled out, no pneumothorax or hemothorax on the other side or on the same side also, then I consider it like what can be done?
No, one possibility is
okay, Dr. Sudhir, I'll go back
low
to
tidal
you.
volume, high oxygen.
Okay, Dr. Sudhir.
Practically is simple. If oxygen is not being maintained and progressively there is desaturation, either
you want to stop the surgery.
Yeah, you stop the surgery, check what is happening. Most commonly, we have published one report also in JNA that same patient with pediatric trauma, airway pressure kept on increasing without any relentless. Whatever we did, it went on increasing. Then I stopped the surgery, took out the tube. The tube was blocked. The tip of the tube was blocked with a big clot. So then once I changed the tube, things became all right.
So see, when you're alone, all the problems stuck. Patient had oropharyngeal bleeding, all these things. And Dr. Rahul, yes, yeah.
Again, one practical tip is you have checked everything. Everything is fine. Please check your HME filter also. I've faced problems once. I know I faced it once. I was able to diagnose it in time. Your HME filter can be clogged, and that can be causing all the problem. You'll be left at sea. You checked everything and you can't figure out, check your HME filter.
All right. So I'll tell you how this case was managed and what happened to this patient. So when that scenario, again, the hypotension was there. So an additional dose of vasopressor was given, and all the routine checks, whatever you said, was conducted. A section was done. There was no kink or there was no block in the ET tube, but there was some blood stain secretions which are coming not significantly. And like Manish said, because the right side there was a pneumothorax and ICD is already in place, so we didn't suspect a left-sided pneumothorax. The air entry was good, so with high airway pressure, lung recruitment maneuvers were done. The saturation improved with lung recruitment maneuvers, but only transiently. After that, the saturation would fall again. So again, the maneuvers were repeated while the surgery was on. So this is how intraoperative it was managed, and I'll come back when we go to the postoperative ward and what exactly happened to this patient. All right. So in this case, once the bone flap is out, as expected, there was huge hypotension and the brain was significantly bulging. So, I would like to share the image with you. So the brain was significantly bulging. So how do you manage a brain bulge, Dr. Sudhir?
The physical things first, rule out all any mechanical causes, your position of your head, any venous drainage, everything, all those things are all right. Your airway pressure is fine. So once these things are ruled out, then if there is a malignant brain bulge, then hyperventilation is what is going to help you initially. So transient hyperventilation initially, at the same time you give mannitol or 3% saline, whatever is your choice. So and then increase your propofol concentration. Switch over to TAVA completely.
So I just forgot to discuss about this hyperventilation. When do you initiate hyperventilation in this patient? This patient is in core brain situation from the beginning in the ER. Yeah. So your hyperventilation should start from ER or after the CT scan, or as you are saying now, only when you see there is a brain bulge.
Yeah,
so
I would
start hyperventilation.
Yeah, because of this, even though there is core brain situation and there is a herniation, other measures, what can be done? They have to be instituted first before hyperventilation. Hyperventilation, you cannot have a control. The patient is in the ER. You don't know what is the ETCO2. Well, transition when the patient is being transported. Hypoventilation is equally dangerous.
I think nowadays most of the ERs are equipped with ETCO2 because for confirming the tube placement, it has become a mandatory thing. When you have an ETCO2 available.
Not all ERs, sir. Not all ERs.
Okay.
We are still in a high volume situation. No, it cannot be done. So in the OT, I would prefer once you get into the OT in a comfortable zone, then you decide upon your pressure, then institute hyperventilation. I would keep hyperventilation until I find a situation like this where there is severe malignant brain bulge. So that hyperventilation will definitely help in that situation.
Okay. So do you think in this scenario of malignant brain bulge, your hyperventilation is going to work because you know whether your CO2 reactivity is going to be intact in this scenario? If your
Assuming,
CO2 reactivity is intact, then only it's going to work.
yeah. Whatever happens, others things might not work. Carbon dioxide reactivity will still be retained for a long time. So initial hyperventilation is always beneficial. That will give you time to start other therapeutic maneuvers, which can take over later. So
All right.
yeah.
So for how long will continue hyperventilation? Because already the brain is bulging.
That's what you start hyperventilation. You give your mannitol. You
Mannitol 3% has been already given for this patient.
Yeah, you try for 10-15 minutes if it is not.
The patient is in hypertension on about 25 mics per minute noradrenaline. So what is your take on giving mannitol?
You can still I would prefer if 3% saline is there. It's fantastic. Nothing like that.
It is available. So how much you would dose it? 3% saline.
3% saline, 5 ml per kilo or 100 or 250 ml in an adult patient. This particular patient will be fine. And that's what you start hyperventilation. You give these drugs. You step up your propofol. Still, it is not getting controlled. If the surgeon is able to access the ventricles, I don't think that's possible. Let out your CSF if possible. I don't think that in that situation. Then
rather, I would just put a simple question. Rather that the brain bulge is expected because of raised ICP, nothing much could be done. Just close and come out. Should that be the goal, or you have to apply all these measures like this? Because is there any data on post-decompression malignant brain bulging and the treatment strategies in that, whether it is going to work? Because when all the medical strategies fail, we go for decompressive craniectomy. That is how the traditional ladder of maintaining, of controlling the ICP. So in this case, should we just stop and just close and come out rather than trying so many maneuvers, which could be counterproductive, like our viewers are saying here, like Navdeep is saying that in this scenario, hyperventilation may be counterproductive. So what is your take on that?
I don't know. Initially, I would still prefer giving hyperventilation a chance. And then other measures. If nothing is working, your medical management, your maneuvers are not working, then there is no option. You have to come out, closing the flap.
All right. I'll get comments from others also. Yeah. Dr. Prasanna? Yeah.
Yeah, when you have done everything and it's not working, nothing much you can do. Do a lax duroplasty and keep the bone somewhere in the bone bank, preferably in the bone bank in these cases than keeping it in the abdomen. And so come out and do a CT. Quick CT scan.
Yeah.
So CT scan. Yeah, because there can be a contralateral this one, EDH or STH.
Yeah, Dr. Manish.
Quick CT scan.
They're the same thing, because something which is not controlled by surgery, it is very unlikely that any medicine will give any benefit. So they're better to do lobectomy or more aggressive surgery rather than just jiggling with mannitol or hypertension. And as Prasanna says, CT scan should be done to rule out the other side, pathology also.
All right. Okay. Dr. Rahul, you have any literature on that? See, that we encountered most of the cases of refractory ICP, or in cases like this, when we expect a malignant cerebral bulging after removal of the bone flap. Are there any effective strategies for that, or you just have to everything?
The literature is silent on it, because as it is, the decompressive craniectomy is the last fourth tire you are doing decompressive.
I always wonder when so many people come and write out that after decompressive craniectomy, brain is bulging and a lot of edema, mannitol, 3%. Is it going to be really protective or counterproductive? That's my question exactly.
I'll just put in one factor here, which is actually still a large-scale randomized trial is required, but few studies have shown that normobaric hyperoxia will at least try to maintain the brain oxygenation. Because
normobaric, what is that?
Normobaric hyperoxia. Now, under normal circumstances, hyperoxia will lead to a cerebral vasoconstriction. But here, the blood-brain barrier is deranged. The cerebral autoregulation is deranged. So, a normobaric hyperoxia in some studies has been shown to at least preserve the cerebral oxygenation or brain oxygenation till you take control of the brain bulge.
So, as Dr. Sudhir rightly said, should you is this brain bulge an indicator of poor outcome, or it is just a pathophysiological process which is happening in the head injury and it's going to resolve with time? Should we attack this brain bulge very aggressively, including rescue therapies like going for a CSF drainage by doing a cystinostomy if possible? I don't think in this brain it is possible, or putting a EVD catheter if possible with the help of an ultrasound, or by medical measures like putting him into barbiturate coma with high dose vasopressor support, or what Prasanna hates, the hypothermia. Does it have a role in this scenario? Yes, Dr. Prasanna, for you only the question is.
No, I think there is only one literature which can be available for this, is poor prognosis. Okay, whatever you do, I don't think you may end up saying when the malignant cerebral edema is there, you may try because you are human and you want to persist trying. Some point try, you can try, but you take the consent of the family, explain them the poor prognosis because the costs are going to be very high for all these things. So explain them the very grave prognosis because they should not be given any false assurances that it may improve, because despite of that, the prognosis is going to be bad even if the patient survives. So somewhere you need to take a call. It's very difficult to define when you are going to stop or what you're going to do. It's very,
yes, Dr. Rahul, yeah, Dr. Rahul, yeah.
Yeah, I fully agree with what Dr. Prasanna said, and that is what was the final conclusion of rescue ICP trial. You are able to reduce the mortality, but at what cost? The outcome is not good. So you have to take the NOK into confidence, whether are they willing to accept that outcome, because here you've got a malignant bulge. In spite of your best measures, you have limited, you have exhausted all the medical therapies. Patient is already undergoing decompressive craniectomy. In spite of that, if there's a malignant brain bulge, we all know the prognosis is going to be poor. And even if you reduce the mortality, at what cost? The rescue ICP trial, the biggest factor against is that the mortality was reduced at the cost of the favorable outcome.
All right. Okay, Dr. Manish, your take on this?
It is poor prognosis and nothing much can be done at this point. I also think that, as Dr. Rahul said, hyperoxic therapy, I don't think will work because it is totally unscientific thing. You cannot improve oxygenation when the hemoglobin saturation is already 100%, because oxygen carried in soluble state is a fraction of the total oxygen of the blood. So that it is totally unscientific and it is not going to work.
Hey, Dr. Manish, there are studies. I'll post on the.
Please do post. This is going to be in the Facebook page. You can post so that are in our WhatsApp forum.
There is a study. That what Rahul is telling is based on the study.
No, Rahul is an electrician man. Whatever he says, he has an evidence. So what I want to ask you is, Manish, therapies like 3% saline mannitol in a hemodynamically unstable patient, when it is not having any proven benefit in this scenario, just for the sake of giving, because we don't have anything else to do, just we are giving, or it's how do you control this kind of management?
There is no clear answer to this. See, when we know that nothing is going to work,
that's exactly the reason we are discussing it here with experts.
When we already know that the prognosis is very bad and things are not working out, then we try to do something which is probably less harmful, or which may...
Hypothermia?
Again, the hypothermia is in the same class. It is not going to help, but you can use it. There is no other therapy available. So that you...
what did you say? You are going to use it?
No, I'm not going to use it.
Okay.
I'm just saying that the knowledge of this, that it is not going to work, you can use it.
Okay, Dr. Prasanna, is there any role in this scenario as a rescue therapy? Just you said that prognosis is going to be poor.
Yeah.
So
but there is no role of anything actually. If you take seriously, there is no role of anything. Hypothermia is also in head injury. It is now no more. It will be practiced. Even Dr. Cooper has given it off. So I think you should and Ashish should leave it off. So, but sometimes we need to accept the disease is so bad that whatever you do, it is not going to be beneficial. That is the reason even if you see the Western literature everywhere, there is nearly half, 50% mortalities and all in the head injuries. But as far as the outcome is concerned, rescue ICP trial, there are different views of different people. So some of the most optimistic people say, at least now we are able to reduce the mortality. Maybe in future we'll be able to improve the outcomes.
All right.
Okay, so that is the reason rescue ICP2 trial is going on. I think NIMANS is a part of it, if I'm not wrong. Yeah, Sudhir.
Dr. Sudhir, what will be your transfusion strategy in this patient? So when do you start transfusion, blood transfusion?
There is no hard and fast rule for that. Again, there are no literature available. So what we do generally is we have a
I'll put it like this. Has your transfusion strategy changed from the time you are a resident, from the time you are a junior consultant, and now you are a senior? So has your transfusion strategy changed over time in managing these patients?
I would say a slight change, because one thing, if you have, everything should be objective. So there is no point in transfusing where there is no necessity. Point number one. Point number two is, now you have point of care devices available. So what we do is, and we have, it has been confirmed that point of care devices like HemoQ, the results are almost similar to your laboratory values or your arterial blood gas. If you have an arterial blood gas, it gives objective of what is happening with your hemoglobin. So you take it as a guide and transfuse if required. Otherwise, I would hold on blood transfusion as much as possible. There is no need of transfusing when there is no need.
All right, Dr. Prasanna, you have a liberal strategy and a very conservative strategy like Dr. Sudhir.
No, because the objectivity of assessing the blood loss is lacking.
Correct.
Okay, there is no objectivity.
That's exactly the reason I asked this question.
So there is always, it is going to be subjective. As a resident, I was very much interested in restrictive transfusion strategies. As a consultant over a 10 years practice, I have moved on to the very liberal transfusion practices. When I have a doubt,
including FFP and platelets?
Huh?
Including FFP and platelets?
Yes. Because when it is diffusely oozing and I don't have anything, so there is no point of having a point of care device and show the surgeon that, see, everything parameters, don't treat the numbers, treat the disease. If you find there is a oozing, there is something inside, which our tests may not able to find out. Still, I would give the benefit of the doubt to the patient to give the FFP and platelets. Okay.
Dr. Manish, would you agree with Dr. Prasanna in this?
Yes, I agree to this. The fourth is not to treat the numbers.
So your practice has changed over a period of years?
Not much.
Not?
Not much.
Okay, so you are using a liberal strategy for blood transfusion throughout?
Yes, liberal strategy to make the patient stable.
If
the patient is stable, I would not do anything.
Yeah, Dr. Rahul, I think a lot of literature is on this regarding blood transfusion, the hemostatic transfusion of giving 1:1 or 1:2. All these things are, literature is filled with this research. At least my practice has changed. Initially, I started with a liberal strategy, then I went for a restrictive strategy, and now again I come back to a liberal strategy. So finally, my guru was right? Okay, Dr. Rahul, yeah, just show me the literature.
Again, the literature shows no efficacy of liberal strategy. But then that is all. The literature also says that one size doesn't fit all. Exactly. You have to individualize your transfusion strategy as per the patient, whether the patient has got any comorbid condition, coronary artery disease, or any problem. But definitely, there's one statement that liberal strategy should not be followed for all. But at the same time, it doesn't say that restrictive strategy is better. First of all, the quality of evidence is not very good. So what is currently recommended is to go for an individualized approach based on multiple parameters, which have already been discussed by the August faculty.
Okay, all right. I take that point. And now,
Ponniah. Yeah, this much of the restrictive strategy studies where they are done in adults or pediatric patient, Most of the patient do not address a bleeding patient, acutely bleeding patient in the OT. As far as the operation theater is concerned, it is still very much subjective. Better to err on the other side than not giving the patient and harm.
So better to go for early transfusion rather than wait till the patient become coagulopathic, hypothermic, and acidotic.
And the second point is 1:1:1 of these trials of massive transfusion protocols. Most of these studies are from Iran-Iraq war and the Afghanistan war, Taliban war. So this is the only thing where war has helped us in understanding. But we need to know that they are all retrospective trials. Only one trial is there, I think, till now, which has been prospectively conducted. All are retrospective series. Even if we are not able to achieve 1:1:1, at least 1:2:2, something giving FFP and platelets positively does going to help. That is what. So because in the Indian setup, 1:1:1 is going to be very much difficult. At least give liberally whatever is possible. That is what is my take.
Yeah, and I totally agree with Dr. Prasanna. And one more thing which I brought out earlier also, there have been two very well-planned animal trial studies which have shown the efficacy of FFP in reducing the brain injury in these patients.
Okay, Dr. Sudhir, we agree with all those things because a lot of consultants believe that they go for their practice has changed over years. So
that's what, again, one shoes does not fit all. It has to be individualized on that particular patient, that particular situation, how you feel, the brain, the bleeding, the preoperative coagulation status, what was happening to the INR, and whether the patient was on any anticoagulants, whether the patient has any cardiac disease, other disease. All these things matter when you decide transfusion. So the best person to decide transfusion, how to give it, when to give it, whether 1:1:1, if facilities are available or what facilities are available at that point of time, will be the consultant who is handling that case. So I would say you individualize it to your patient and your scenario and go ahead.
So during this emergency cases, most of the times we land up in inadvertent hypothermia, as well as if you do regular ABGs, you find some metabolic acidosis.
Yeah.
So how do you handle such scenarios?
One thing is there, when with a lot of things happening in the primary pathology of head injury, so much of confusion going on, transfusions, some amount of hypothermia acidosis will always be there. If there is severe life-threatening acidosis, it has to be treated. Otherwise, your vasopressors or inotropes also will not act. So if there is a severe, significant acidosis, you treat it. Otherwise, moderate hypothermia is still protective. Whatever Prasanna sir might not have a view, but there is nothing concluded as such. So you allow moderate hypothermia. If it is going, automatically leave it at that. So don't aggressively try to correct it.
So for acidosis, do you have the habit of giving soda bicarbonate and things like that, especially when your inotrope, when your vasopressor requirement is high, or you want to add one more vasopressor?
Yeah, not routinely. If it is less than going below 7.1 or 7.2, then only then some treatment has to be required.
No, because there are a lot of trials now coming about soda bicarbonate in brain injuries as well. Dr. Prasanna, your take on this?
No, we do not follow routine bicarbonate therapy for all cases. No.
All right. Yeah. Okay. Dr. Prasanna. Yeah.
Why there is acidosis? Rather, I would want to treat that. So acidosis is there, and increasing lactate means that there is a tissue level perfusion issue is there.
Correct.
So the inotropes only is not going to help. Resuscitate the patient with fluids and blood, all those things. Get the oxygenation correct, and
no, just as a temporary buying measure to.
I don't think adding another vasopressor is going to help. It is going to cause further vasoconstriction and reduce the tissue level perfusion some more. So rather, I would resuscitate the patient, and as long as soda bicarbonate is concerned, yes, if acidosis is very severe, like 7.1 or less than that, definitely I would like to treat at least as temporary, because in the milieu of acidosis, our inotropes may not act into the extent what we desire. So maybe that is the reason I would give, but I really don't know how much it is going to help. But I would give definitely.
All right. So let me tell you what happened to this patient by sharing my screen. So the surgery, it was brain bulge. The brain was closed, and once the brain was closed, the opposite side pupil was dilated. Right.
Okay.
So this patient was wheeled in for a emergency CT scan. If you could see my screen,
Yeah, opposite side. Yeah.
Opposite
Yeah.
side.
So
Stage.
in the opposite side, there was an EDH.
EDH, definitely.
EDH or STH?
Right.
EDH or STH? EDH.
Both, both.
Both.
It looks like a combination of both.
Yeah.
More of an EDH.
Yeah.
So, Prasanna, what do you do in this scenario?
Nothing, you have to take for surgery.
You have to reopen it.
And decompress that on the opposite side also.
That commonly happens in our scenario also. That's what, if there is a malignant bulge intraoperatively, most of the time it is an opposite EDH. Or else if the brain is bulging slowly, that is because your surgeon has occluded many veins, the channels of veins which have occluded.
So there are surgical factors also, you mean to say, yeah.
Yeah.
Okay, so he was taken for, meanwhile, remember that intraoperatively we had problems of maintaining his saturation as well. So let me tell you what happened to him. So post-operatively, we did a chest X-ray. So would you do the same thing, Dr. Prasanna?
Yeah, sure.
So we did a chest X-ray. So this was a chest X-ray. The lungs were expanded. The left side lung, maybe we thought it was a rotational film, and the ICD was in situ. There was nothing much, but still he was requiring very high FiO2 and PEEP to maintain the saturation. So what next, Dr. Prasanna? I've shown you the chest X-ray. So we thought it could be aspiration because it could produce an ARDS and things like that. It could be collapse or something. So what next?
You have to use high level of PEEP.
Okay, right.
So and high level of PEEP and get the oxygenation right, because oxygenation is going to kill you more than the hypoxia is going to kill you more than the other.
You saw the chest X-ray. It's okay. You are happy with the chest X-ray?
No, we couldn't see. You have not shared the screen.
Oh, really? Okay. Just I'll share the screen.
Yeah.
So, yeah. Okay. So this is the X-ray.
Yeah. ICD is on the right side, right? Okay.
Correct. Yeah.
Left side. Yeah. Okay.
Left side.
Yeah, the subclavian line was placed post-operatively.
Yeah, right side. Yeah. Okay.
Just X-ray.
That's true.
So what next?
What next?
Sedate and ventilate. I would prefer to, if the patient is in ICU, sedate, ventilate. If nothing is helping, relax him and ventilate. Use ventilation strategies also can be changed. Low volume, high frequency. These kind of ventilation strategies can help in this patient.
All right. Yeah, Dr. Rahul, your comments, please. Yeah.
Actually, if you have to start with the lung protective ventilation, if nothing helps, then there's enough literature which supports the proning of these patients to improve the oxygenation, because here now the primary thing is you have to prevent hypoxia. So proning is also an option in these patients. In ARDS, full-blown ARDS, early proning to improve the oxygenation. Early proning.
All right. So this patient opposite side EDH was evacuated, and people becomes slightly equal, and a quick bronchoscopy was done in this patient. So let me share the bronchoscopy finding with you. Okay. So in the bronchoscope, this is what I could see.
Oh, blood clot.
Yes, yeah.
Big blood clot.
So the chest X-ray didn't show actually a big collapse or something. Maybe we would miss out some collapses in chest X-rays. Usually we expect a white out lung and things like that. But it was just a bronchoscope. Just before I left, I did this bronchoscope, and this was the finding. So once the plug was removed, the saturation improved very dramatically. So managing this kind of patients are always a challenge, although it is always left to juniors, both at the surgical side as well as at the anesthesiology side, these cases are left to the juniors to manage, but this is always a challenging scenario. It's not a very easy scenario, managing a patient coming with polytrauma and a head injury for a decompressive craniectomy. And we had a lot of discussion today. I'm very happy that this was very interactive, and I was very happy that a lot of people participated in the live chat, and a lot of discussions which happened in the live chat. I think these discussions will take it forward as well. Some of the discussions, some of the main points, I'll just go through it. People are talking about maintaining the glycemic status. Sometimes we see even in non-diabetics, the blood sugars will be 400, 300s and things like that. So what is your strategy, Dr. Sudhir? When do you start correcting hyperglycemia?
So that's what, if it is 400, it's again alarming. You have to get it down. Anything around 180 to 170 is what is recommended. So keep your sugars at around 170.
The sugar in this patient, the sugar was 400. So when do you start correcting? We'll wait for the surgery to over, or intraop itself will start?
No, intraop you start correcting. Get down your sugars to less than 200 and maintain it at that. That's what I would prefer to do. So don't, aggressive high correction of sugar is also not recommended. Keep it around 170 to 200. That should be reasonably okay. And post-operatively, you can manage it strictly if whatever your institution protocol is being followed.
Dr. Manish? Glycemic control, because often the sugars are very high.
Yeah, the purpose is to keep the sugar around 150, so that I would start usually intraoperatively. But the sugar, falling sugar should not be very abrupt. It should be less than 75 milligrams per deciliter per hour, so that by with the continuous infusion, targeted infusion, it can be achieved.
Dr. Prasanna, your strategy of glycemic control?
Same, 140 to 180.
Okay. So I'm just quickly going through the chats which are happening and trying to answer those questions. Colloids, is there a role? Dr. Prasanna?
I use them. When there is acute hypertension and
you use them. Then I just directly go to Dr. Rahul for literature. Dr. Rahul, colloids.
Colloids not as a first choice, but definitely, as I showed, that one can go ahead with the FFP based on the limited evidence available. But as a first option, isotonic non-glucose crystalloid.
That is fine. Is there a role for colloid you should use, not use, or can use?
Colloids, as per the evidence, ideally should not be used until unless
absolute no, as per the evidence.
Absolute no, until unless there's any other systemic injury like
absolute yes. There is absolute yes as far as the clinical utility.
Clinical utility. Okay. I think Manish, you agree with that?
No. When you are tired with giving fluids and you are waiting for the blood to arrive, you can get colloid in that. So
yes,
it is the time when you have exhausted your fluid solution and you don't have blood in. Because if you have blood in, better to practice rather than.
Okay, right. Dr. Sudhir, do you use colloid in your practice?
Excellent. Like what Manish, Dr. Manish told, if you don't have blood, then colloid might come for your rescue. If you have blood, go ahead with blood transfusion.
You will never have that much blood.
Okay, so the consensus or the ideal thing would be not to use colloid in these scenarios. Always prefer blood products. All right.
And take my words, colloid is going to come back again in next 10 years.
I'm waiting.
Yeah. Next 10 years. Yeah.
So we discussed about crystalloids and normal saline. So it's already people have discussed about that. About anti-epileptic drugs, which has been discussed. And the BP target, like everybody agreed, it should be tailor-made, and there are signs of herniation and increased ICP. You have to aim for higher blood pressure and rather not treat the hypertension. Or you should be very careful, especially when you are giving drugs like propofol, which can cause profound hypertension. You should always be ready. Foleys is dangerous to the nose. In the nose, it's dangerous. That's what everybody believes. So use measures like putting a good pack for the oropharyngeal and nasal bleeding. And then people are talking about cava fix and things like that. So as we discussed, central lines, whatever you are familiar with, when you don't have a line in this scenario, always you need to have a good IV access. Having said that, a 2 wide bore line is enough to conduct this case, we should not waste time in getting a central line, because getting out the bone flap and reducing the ICP is very crucial in this case. DVT prophylaxis. Do you even think about DVT prophylaxis when you're doing this? Right?
No.
So DVT prophylaxis comes in the ICU. Of course, we'll start with mechanical prophylaxis, then proceed with low molecular heparin. And maybe we can discuss in a second topic when to initiate low molecular heparin, because not in the scope of the discussion today. So opioids, about TB and inhalation controversy, we discussed in great deal. About the reactivity of the injured brain to the anesthetics. So we also discussed about that. About hyperventilation, yes, we discussed mannitol and the, okay, whatever it is, we discussed most of the things. So it was a very fruitful day. We had a very great discussion, and thank you, Sudhir, especially for coming and sparing your time and sharing your experience.
Yep.
Thank you so much for attending that. And I need not thank Prasanna and Manish. They're always there in my show. So they are part of the show in classroom. Dr. Rahul, thank you so much for your literature review, because you're always very meaningful and with solid evidence. It's not an expert opinion. Thanks, Anil. I made you wait.
Thank you, sir.
Thank you.
And I hope you enjoy this experience. Okay.
Yeah, definitely.
Thank you all. Thank you all, the viewers,
Thank
for
you very much.
supporting us and watching. Thank you so much. We'll meet you in the next class with another interesting topic. Thank you.
Thank you. Good day.
Bye.